Hi there, everybody. This is Dr. Gibbs, and today in the Tuesday Live, we are going to delve into the practical and philosophical differences in how myself and my clinic treats hormone imbalances versus what you can expect if you go to a traditionally trained endocrinologist. And it can actually really be summed up in one sentence. So, an endocrinologist that I was listening to recently, when asked about a particular new diagnostic tool, said, I find insufficient evidence that XYZ is effective. And what he meant by that is that there are no randomized, controlled, double blind, placebo trials that show significant evidence that that particular proposed treatment has been proven to work statistically for most people. Um, and the problem is, if you're not most people, then this treatment strategy may leave you hanging. So today, I do want to compare and contrast this with a philosophical bent towards using an individual's particular situation and years of clinical experience and personal experience to inform any particular diagnostic criteria or treatment that I use. Now, that's not to say that this kind of research, when it has been done, is not admirable, particularly when it's confirmed by follow-up studies from different researchers that confirm those same findings. But there are a lot of reasons why this kind of quality research frequently are not available to answer a particular clinical question. The first thing is that it's expensive. I mean, really expensive. So most of the money that's spent on clinical research these days is funded by big money, either big pharma or by the NIH, and it's conducted in big academic institutions with big reputations. And they don't want to stick their necks out a lot of the time. Um, and much of this research is actually driven by an agenda. And when I say that, I'm thinking about the Women's Health Initiative, which was a multi-center study done by several previous really prestigious institutions. And it cost nearly $1 billion to do, and it set medical care for menopausal women back 20 years or so. Um, or by the companies that stand to profit from positive results, like drug companies, for example. Um, the other thing is that those treatment studies have to have lots of participants and lots of control groups and randomization in order to actually prove beyond a shadow of a doubt that some particularly treatment is statistically significantly effective. Um, and if they're asking the wrong question, it can make it look like a particular treatment doesn't actually work. For example, if the dose that they used wasn't sufficient, or if they didn't check the people's blood levels and they gave everybody the same dose of a particular medicine without knowing whether they even needed the medicine or not. Um, so if you're in the minority of people for whom the mainstream diagnostic measures and or treatments aren't effective, you're kind of out of luck and left behind by this treatment philosophy, which is I'm not going to do anything unless it's really proven to be effective. And I'll give you an example of this because when studies are done where they ask the question of which treatment is more effective, levothyroxine or natural desiccated thyroid, it matters who's being treated in the treatment group. For example, what are the severity of their symptoms versus what are their lab values? Are they done for SH only versus are they also checking whether they have low T3 or not? Not to mention T3 is almost never done. It also matters how often and at what dose the treatment is administered and how they determine whether the treatment is working or not. So, like, did they check the patient's blood levels again after the treatment? So, by most of the clinical criteria which have been studied, levothyroxine is the clear winner um, until you ask the patients. And some of the studies actually did that. And then a large subset of those patients will say the natural desiccated thyroid actually made them feel better. Interesting, huh? Um, and keep in mind that entire group is generally getting the exact same dose in any given study. Um, and when clinicians who treat thyroid patients, particularly Hashimoto's disease, know that the requirement for thyroid replacement is actually really all over the place. Why else are there levothyroxine doses ranging from 12.5 micrograms all the way up to 300 micrograms? Anyway, high quality evidence of the kind that academically inclined endocrinologists generally insist on, which is most of them, tends to lag newer treatments or diagnostic modalities by a minimum of 17 years or sometimes 30. Um, and physicians who don't have academic support, who try to publish clinical observations or smaller studies, are frequently dismissed as not relevant by the big major publications if they don't have academic prestige or money behind them or a pedigree of prior publications. And the prestige may not be able to rock the boat, so to speak, even if they have clinically observed similar type issues without endangering their status. But there are evidence that's out there, and there is clinical experience, sometimes a lot of it. Um, Now, I'm not saying that this gridlock on new ideas is unique to endocrinologists. I mean, think about Dr. Atkins, who was ridiculed for his Atkins diet right up until his death. I wonder if he's sitting up somewhere watching as his ideas are vindicated and low carb becomes the diabetic diet of choice. Oh, wait, diabetes is an endocrinology disease. Okay. Anyway, I wasn't intending to rant. So, what I do want to talk about is how my training and my methods are different than what you're going to get at an endocrinologist office, particularly those who take insurance, which is almost all of them. Um, so, the first one is that I have time because I am not dependent on an insurance company to pay me a certain copay. And because I don't have to pay out most of what comes in to the staff who collect the money, um, I can afford to see fewer patients and spend a lot more time with my patients working on everything to do with their hormones, not just the particular issue that you came in for. Okay, I feel tired and I think I have Hashimoto's disease. Okay, that's awesome. We can work on finding out whether you have that or not. And if not, I have a lot of other diagnostic criteria and other hormones and other things that I can branch out to and look at with you to help you figure out, okay, why are you tired? Why are you tired? And what can we do about it? Um, anyway, so that's one way. The fact that I have, because I'm not dependent on insurance, I have plenty of free time. Also, because I am a surgeon, I am not really limited to, okay, well, this is out of the field of endocrinology, therefore I can't take a look at it and help you figure it out. I'm a surgeon. I like a permanent fix. I like to know what's causing the problem. So your thyroid levels are too high. Does it have a cancer in it? Should we do a biopsy? Should we have you have it taken out? If your stomach is making too much acid, um, you know, surgeons used to cut the nerves to your stomach, and that was a thing right up until it was determined that peptic ulcers are actually caused by a particular kind of infection. But as newer methods for blocking acid came online, it became a very infrequent thing to cut the nerves. That's called a vagotomy. And it is still ever so infrequently done, but mostly it's not needed anymore. And surgeons did not stop looking for why people got ulcers just because they had something that seemed to work. They kept looking for newer methods, and when they came out, they started using them. Anyway, my point is that surgeons are pretty quick to look for new ways of doing things when older ways fail, considering the individual person and the quality of the evidence in jointly making a decision as to what to do. And what I have found is that in thyroid treatment, the old ways really do fail up to 20% of the patients who get put on thyroid medicine. And that is really not even considering many, many people who have Hashimoto's disease who don't even know that's what they have, who've been told there's nothing we can do, your TSH is normal, and that your fatigue is imaginary, you're just depressed, here, take an antidepressant. Really, I am very, very strongly of the tendency to try and try and try to help you figure out what is going on and continue to try different methods to get that fixed. And until we are satisfied that we have tried everything else, we're not going to stop. And if that means we're going to try some stuff that's not quite in the mainstream, then we're going to try stuff that's not quite in the mainstream. But anyway, that's kind of all I had to say for today. Anyway, I'm Dr. Dana Gibbs. I am an integrative thyroid and hormone management physician here in North Texas. I would love to help you out if you have been told that your thyroid is normal and that your symptoms are not one reason or another. So come see me. My is www.com, and I take in virtual appointments in Texas. And I would love to help you. Talk to you later. Take care. Bye.